Okay, so good afternoon, everyone. My name is Achawin from Thailand, and I will be presenting the case for the OCCPC for today. So today we have a case of 66 years old Thai woman who was referred to kidney clinic due to the history of foamy urine and bilateral legs edema. Her previous medical history includes hypertension and hyperlipidemia, and her chief complaint was legs edema for 3 months. 3 months ago, she began to notice abnormal pitting edema on her both leg as well as her foamy urine. The process tend to be progressive over 3 months, and she reported that she recently experienced some weight gain, and she began to feel more difficult to control her blood pressure at the time. Her average home BP monitoring went from 130 over 70 to 150 over 90 millimeter mercury. There was no change in amount of daily urine volume, approximately around 3 to 4 times during daytime and nocturia. The patient denied history of gross hematuria, no orthopnea or PND, no significant weight loss. She had no fever, no joint pain, no rash, and no history of hemoptysis. She denied history of any possible nephrotoxic medication use, and she did not receive any medical therapy or diuretics since the beginning of the symptom. One day before admission, she came for her regular follow-up at internal medicine clinic, and her serum creatinine went up to 2.3 milligram per deciliter from prior baseline of 0.9 6 months ago. Bilateral pitting edema was seen, and her doctor consulted nephrologist, and the patient was admitted to the hospital. For past and personal history, the patient denied history of alcohol consumption and smoking. She has no history of recent infection. She denied history of drugs allergy. She denied history of illicit drug use and herbal medicine use. She has no history of recent vaccination, and her current medication was lecanidipine 20 milligram per day and atorvastatin 40 milligram per day. Family history has nothing significant. Only her father had history of hypertension at the age of 55, and her 2 siblings as well as her 2 children are healthy, and no history of kidney disease in her family. For physical examination, the blood pressure is high 100 over 67 over 85 millimeter mercury. She did not obese with the BMI of 23. She is in good conscience. The patient has pale conjunctiva, no jaundice, no oral ulcer. The thyroid glands are both in normal size, no lymph node enlargement, no mala or discoid rash. Cardiovascular system was normal, and no sign of heart failure was detected. Respiratory examination was normal. Abdominal examination was unremarkable, no mass or no enlargement of liver and spleen. We found pitting edema on her both legs, no skin rash were found, and no superficial lymph node enlargement as well, and neurological system was intact. For initial investigation, the patient has azotemia. Her creatinine was 2.3 with the previous baseline of 0.9 milligram per deciliter from 6 months ago. There are no other abnormal electrolyte abnormality, and her serum albumin was low with a level of 2.4 milligram per deciliter. For the urine analysis, we found microscopic hematuria with more than 50% of dysmorphic red blood cell on the fresh smear, and also nephrotic branch proteinuria with the UPCR of 6.9. The patient had anemia with hemoglobin levels of 8.1 gram per deciliter. We can see that the MCV is in low normal level, and the RDW is quite wide, so we work up more for iron deficiency anemia, which is turned out to be negative. And Coombs test was also negative, both DCT and ICT. For the serology, we found no C3 complement levels, normal C4, otherwise negative, including ANA, anti-double-strand DNA, anti-HIV, and all viral hepatitis profile are negative. Chest X-ray seem to be normal. There are no abnormal infiltrations or mass, no pleural effusions, no cardiomegaly, and no abnormal bones lesion on the X-ray. As for the ultrasound, the kidneys are good, both in normal shapes and size. No sign of CKD was detected, and there are no mass and cysts and no hydronephrosis. So that's the case. And any problem is?
So is anybody want to volunteer to list the problem first? And anyone from want to volunteer? Otherwise, I gonna be go by country. No. So maybe start from Malaysia. Anyone from Malaysia want to volunteer? Anyone from Selayang? Selena, do you want to ask any fellow from Malaysia?
Sorry, Golf,
Sure.
are you asking me? I think we've got somebody about to volunteer there.
Yes. No, because I don't know a Malaysian guy friend, so maybe Harshana may help me to ask for volunteer.
Okay, I'm trying to look for the Selayang. There's only one labeled the Selayang fellow, and I'm not sure who that is. I'm not sure who Selayang fellow is, but could you maybe just list out what are the problems so far?
Maybe because the history is too long. So maybe we just list for the problem list for them, and then we start discussion. Yeah.
Yep.
Okay. So I'll go with the problem list. So we have the four main problems to address here. One is bilateral legs edema with Fermi urine for 3 months, with azotemia with worsening hypertension, nephrotic range proteinuria, and microscopic hematuria, which is supposed to be glomerular hematuria because there's dysmorphic red blood cell in the fresh smear. So wrap up here, we have the patient with nephrito-nephrotic syndrome, I think. The number 2 problems is normocytic anemia, low C3 complements on the serology workup, and underlying diseases of hypertension and hyperlipidemia.
Okay, we
So-
got the problem list. So anyone want to challenge yourself? Oh, keep quiet. So maybe anyone from Malaysia or Indonesia? Or Liza, do you want to try? No.
Maybe Golf, you can ask somebody from home, your side, not the same institution.
Okay. Okay. My side. Any fellow from Chulalongkorn University want to try first? Where is my fellow? Come on.
So basically, you're
Jeff,
asking for differential diagnosis.
Jeff, are you there? No.
Oh, sorry. Okay. Hello.
Hello. Okay.
Okay. I'm the first year fellowship from Chulalongkorn University. Let me differential diagnosis in this patient. The first differential diagnosis, this patient came with nephrito-nephrotic pattern. She present with glomerular hematuria and glomerular proteinuria and low immune C3 level. I think the first differential diagnosis is post-infectious and post-infection related glomerulonephritis. The second differential diagnosis maybe in about autoimmune disease in immune complex group because she is a woman. We cannot exclude about cryoglobulinemia or lupus. So we have to.
One, can I stop you for a while? Before you go to the disease, maybe you start with the syndrome of the patient. So you think that the patient had nephrito-nephrotic syndrome, just that? Because
I
patient
think
have hypertension and creatinine rising for 3 months.
the clinical syndrome, I think, is RPGN,
Okay, antigen, and then
and
do you
then
think
most
it's primary or secondary? And what is this?
I think this is maybe the secondary RPGN, and
And why? Why?
because she has many systemic symptoms like anemia.
Okay, so before you assess, do you want any information from the presenter? Like do the patient have fever or upper respiratory tract symptom, like nasal voice, or like tinnitus or something like that?
So she has no fever and she deny all the chest symptom. There's no hemoptysis and she don't have any history of allergy or any ENT diseases. She also denied all history of the autoimmune system, no arthritis, no arthralgia, no
Okay.
rash, and no excessive loss of her hair.
Okay, good, thank you. วันนี้now you can start assess the case. So RPGN in the female age about 60 years old.
In this patient, RPGNs, I think this cause is from secondary cause, and the etiology, I think, is most likely immune complex, because she had a low complement level. The most likely differential diagnosis, I think the first one is infectious cause because she had a low C3 complement. The first, I think, it is infection-related glomerulonephritis. The second one, the autoimmune cause cannot be excluded because she is a woman, but from physical examination and history, she doesn't have any autoimmune side, but we have to consider about cryoglobulinemia and lupus. And the third one is malignancy-related immune complex because she is an elderly. We will consider about hematologic malignancy or solid organ malignancy, which relate with glomerulonephritis.
Hello,
So
I am the second year fellow from Chulalongkorn. I'd like to add the differential diagnosis. In this patient, it could be complement dysregulation, which may, because she has low C3 complement level, and the complement dysregulation may be result from infectious or paraproteinemia. So I think we have to work up for the underlying hematologic malignancy also.
Okay, good. Before everyone want to before you saying, please introduce yourself first.
My name is Achariya from Chulalongkorn University,
Achariya.
Thailand.
Good. And anyone want to share your idea from the other hospital beside Thailand? If you agree with Chulalongkorn fellow that think about post-infectious and follow with autoimmune disease and comment dysregulation, hematologic malignancy. Anyone have the other differential? No, if no, you can ask for the additional labs. Anyone from Singapore? No. Why today is so quiet? No. Okay. So, Achariya, do you which lab laboratory that you want to submit more or would ask for?
I would like to ask, but immune complex disease is also in the differential diagnosis and the
Yeah, I
patient.
know.
So I would like to ask for ANA, anti-double strand DNA, and C-ANCA, P-ANCA, and SPEP immunofixation, serum free light chain level, and if we can send for the the complement dysregulation, I'd like to send them, but it's not available in Thailand, as I understand.
So the result, are as shown here in the slide, and it was negative, and the double strand DNA was negative, just only C3, just only low levels of C3, and the ANCA was also negative, both P and C ANCA. And as you asked for, we did work up on the serum electrophoresis and immunofixation. Okay. Any more comments?
So do we actually want to send the anchor or ask for anchor or immunofixation? Why we need to do that? Because the patient have RPGN and low C3, normal C4. Which of paraproteinemic coagulopathy that you differential diagnose that raise you to submit immunofixation? Actually, yeah, do you have reason why you ask for that? Even it's positive, but why? Usually for RPGN, we differential 3 groups, post-immune, anti-GBM, immune complex, right? And why you think about the monoclonal gammopathy?
Because this patient, she has anemia and she is elderly, and we have clue from the laboratory that show the low C3 level that could be like a complement dysregulation. So we have to work up the paraproteinemia, especially in the patient with age more than 50 years. So I decide to send the serum electrophoresis and immunofixation.
Yeah, okay. But actually, sometimes some center have not have a limited resources. So otherwise, they will send every case when age more than 60, and they come with RBGN. They need to file the lab to submit the immunofixation and serum electrophoresis. And sometimes it takes time because the turnaround time may not may more than 1 week. So better we should keep it later after anchor complement and ANA is negative, and then when we try to think a rare presentation of rare disease. Okay, anyone want to express any idea? Liza, are you ready? Do you want to raise any issue or comment? Usually I keep asking.
Yeah, sorry, Professor. Maybe is there any calcium level maybe in this patient to raise us concern about the hematologic pregnancy?
Kevin, do you have any calcium level or phosphate level?
Calcium and phosphorus are in normal limits, and corrected calcium is around 9. So the calcium and phosphorus level were in normal limit. Okay.
So it is that always thinking about multiple myeloma. Okay. And right now after you got the labs, so วันนี้ it can narrow down your differential diagnosis, or you want to submit the additional labs or anything.
Now I think we have a clue that she will have a MGRS, monoclonal gammopathy related glomerulonephritis. So we consider to kidney biopsy to prove and send for immunofluorescence and EM and LM.
Dr. Ashwin, can you go back to the immunofixation?
On bone marrow biopsy.
Thank you. So the immunofixation, she has a IgA kappa. Okay, IgA kappa. So and what is the pathologic finding that you expect to see if the patient have MIDD? What kind of pathologic pattern that you expect to see from the pathology when the patient present as a RPGN?
If it is MIDD, we expect to see the nodular glomerulosclerosis in light microscope, or it could be the MPGN pattern also. And in very rare condition, it might present as the crescentic GN.
So if nodular shape or nodular sclerosis or lobulated pattern, do you expect that her creatinine is increased real fast?
I don't think if it's just nodular sclerosis, creatinine might not be rising so fast like this. So it might be like the proliferative GN, as it might be the PGN MID, or it may have like a crescentic GN, but it is very rare in paraproteinemia or MGRS.
And the type of heavy chain that you see from the immunofixation guide anything? Is it still proliferative GN with monoclonal gammopathy, or any flag something, or like because it's a IgA kappa? Or do you want any labs besides immunofixation and calcium phosphate, and anything that you want more? Because we still have plenty of time left. Haven't hear any voice from Singapore. Any Singapore doctor want to comment or share your idea? Dr. Jason, do you see anyone want to share any idea?
Golf, I think, hang on. I don't see any of my fellows here actually. I think a lot of them are away.
If no fellow from Singapore, maybe any fellow from Malaysia? If not, so before perform kidney biopsy, Vani and Achariya, do you want to ask anything before you decide and talk with the patient to start perform kidney biopsy? Any concern for this patient or any collection or preparation before?
Okay. Before prepare kidney biopsy, we have to ask the patient that she has a absolute contraindication for kidney biopsy, like uncontrolled hypertension, uncontrolled infection, uncontrolled bleeding, or patient consent. If she doesn't have any absolute contraindication and consent to get a kidney biopsy, I think she should be considered to have a kidney biopsy and send for LM, immunofluorescence, and EM.
Actually, yeah, do you want to add something more?
So like Dr. Wani said that we have to control her hypertension, and this patient also have anemia. So if we concern about the uremic bleeding, we might keep the hemoglobin more than 10 gram per deciliter to reduce risk of uremic bleeding.
Do we need to collect the anemia before perform biopsy, or what do you do?
Actually, there is no cutoff for the blood urea nitrogen or creatinine that increase
No, I
the
mean
risk.
an anemia level, hemoglobin level.
Anemia.
Because the patient have hemoglobin level 8 gram per deciliter.
If we
It is
concern
safe
about
to- I
the
mean,
uremic.
I just
Oh.
asking. Do we need to raise hemoglobin level? Or do we need to like a group match pack cell to prepare just in case the patient have a complication during biopsy or anything that you have to prepare besides counseling?
Uh,
Or any concern?
in our center, I think we gonna give her the pack cell to keep hemoglobin level more than 10 before biopsy and keep the normal blood pressure and advise about the risk of bleeding after the procedure.
Hello, Imran from Kuala Lumpur. Do you mind show me the result for the patient again?
We're interested in the urea,
Especially the urea creatinine. Renal function, please. Oh yeah, sorry. No, sorry. Renal function. Thank you.
And
The virus screening, because we missed a bit at the beginning.
yeah, this is not screening.
The initial creatinine, right?
The virus screening, the infection screening.
All negative for
All
hepatitis.
negative. Okay, thank you.
Yeah.
So negative.
Okay, thank you.
For me, I think if you differential MIDD or paraproteinemia, but this case is quite rare because you can see globulin level is very low. It's only 1 point something. Can you go back to globulin level? Yeah, it's only 1.6 gram per deciliter. Usually when you differential paraproteinemia, the globulin level is increased. And if the high globulin level in the MIDD, when you perform kidney biopsy, you need to aware of the bleeding because hyperglobulinemia will increase risk of bleeding tendency. Okay, because of the globulin level is not high, and you're gonna raise hemoglobin level to some certain threshold that you satisfy, so we can perform kidney biopsy. Anyone want to share any idea? If not, so we're gonna proceed to kidney biopsy. No, if no, okay. Dr. Ashwin, please review the pathology.
Well,
Teach.
thank you. Okay. We have Dr. Mongkon here, I think.
Maybe you go just overview and ask fellow or anyone want to read the pathology, and then Dr. Mongkon will answer the whole case for us.
Okay. So anyone want to be volunteer for the kidney biopsy interpretation here?
Do we need to give methylpenicillin before? Just, but usually for RPGN, sometimes pathologies take time to review the results. So maybe we may try treat with the methylpenicillin in general, but for this case, so we are afraid that the patient have a kind of paraproteinemia. So we just waiting for the result. Okay, we go to the kidney biopsy. Besides Chulalongkorn, anyone from Wachila Hospital want to explain any idea or read the pathology? Very welcome. Okay, Mongkon, please go ahead to the first slide. Okay, anyone from Wachila or the other university from Thailand want to read? If no, so okay. Actually, yeah.
I will preview just light microscope, and then I come back to the first slide again.
Okay, thank you.
Okay,
Thank you.
You're welcome. Okay, this is my last slide for the light microscope image.
Okay, good. It's a concise, informative. Achalian, you are ready? Are you ready?
Yes.
I think, okay. Better than, okay. A fellow, start with fellow 2. Second year fellow. Okay.
So
Yes.
there are 2 calls from the cortex, mainly from the cortex, and there is a interstitial inflammation, and the glomerular like show the endocapillary hypercellularity and mesangial moderate mesangial expansion, consistent with the I think is with the lobular accentuation, but at this point I did not see the double contour, but I think we have to look from the PAS stain also. But the GBM is quite thickened. I think is consist with the membranoproliferative glomerulonephritis. So in this picture, I think there is a double contour of the GBM.
So actually, which structure of the kidney that contribute rising of serum creatinine? Is it just only glomerular or glomerulus?
I think the glomerulus,
is a major contributing
and
factor.
I'm not sure whether is that the crescent one in one glomerulus.
Is it if just only one, how many percentage of the crescent formation? Just roughly ballpark figure, not have to actual percentage.
Less than 10%.
If less than 10%, is it contributing to clinical of RPGN?
I don't think is
Okay.
contribute to the rising creatinine.
So, and which structure that does it play a major part to increase serum creatinine in this case? Is that glomerulosis or concomitant with the other structure?
So I think we have to look at the tubule structure and the vascular also.
Okay. But majority for the glomerular structure abnormality, do you think that the patient which glomerular pattern for this case?
The membranoproliferative
MPGN
glomerulonephritis.
pattern, right? MPGN pattern. Okay. And Dr. Mongkol, do you have any high resolution for the tubular initial structure and vessel structure? Okay. Oh, okay. We can explain. Good. Now you see the tubular initial. Do you think is it normal or not?
There is the tubule is lot back to back structure, and there is the interstitial inflammation, and the vessel
Is a lost structure of tubular atrophy, or do you think it's acute or chronic? Tubular initial structure injury, is it acute or chronic?
I think is quite chronic.
Quite chronic. So please use technical term to describe tubular initial area.
The IFTA was roughly 30 to 40%.
And plus
And
plus, okay. Tubular atrophy, initial fibrosis, what kind of cell infiltrate?
I
And,
think it's mononuclear cell, but I think it's mononuclear cell. Mainly.
Combined with MPGN pattern and initial inflammation, what do you think the provisional diagnosis by pathology? You need anything else to support?
I think is one of the MGRS, but we need the immunofluorescence to confirm that whether is immune complex or complement or non-complement, non-immune. So the IF would be very helpful.
And from MPGN classification, do you recall the diagram of the MPGN pattern?
In MPGN pattern, we would classify into 3 groups that from the immunoglobulin, and we will classify into monoclonal, like from the underlying hematologic malignancy or plasma cell dysplasia, or polyclonal from autoimmune disease, infection, or idiopathic or fibrillary GN. And the second group is result from the complement dysregulation, which could be C3 glomerulopathy or C4 glomerulopathy. And the last group is non-immune and non-complement. It could be from the thrombotic microangiopathy.
Good. Very good. So any special stain from light microscope that can help you to guide which group that you differentiate, diagnose? Like Masson trichome, silver staining, or PAS that can guide you before you go to the IF.
The math song, it could help differentiate the cause. The zone should be negative and the PAS should be positive. And if it's positive in Mason, it would be fibronectin glomerulonephritis. So I think the special stain will help.
Dr. Mongkon, do you want the one fellow to go to the IF, or you want to answer the LM first?
I will answer the LM first. Okay. So I start with the low power from H&E stain here. Ashriya described similar what I described. This case is straightforward that you can see two nice core of cortex and have multiple glomeruli. But on multiple level, I have got 28 glomeruli and none of which are global or segmental sclerosis. If you see on the low power, you can see the black background of moderate interstitial fibrosis and early tubular atrophy on this area. The cell inflammation on the interstitial atrophy is not remarkable. The glomeruli you can appreciate on the low power that have lobular appearance with increase in mesenchymal cells and matrix, as well as increase in GBM thickness. If you see on PS stain, you can appreciate the nicely double contour here and almost global area that have double contours. And also silver stain confirm that the double contour is very nicely. You have reduplication of glomerular basal membrane on the whole on the global glomeruli and all diffuse pattern. So in this case, it's straightforward that you can see the morphologic pattern of the glomeruli is membranoproliferative glomerulonephritis or membranoproliferative pattern glomerulonephritis. Like you described before, that we have to differentiate diagnosis in 3 categories from this pattern that include the first one is immune complex mediated glomerulonephritis and C3 glomerulopathy and chronic thrombotic microangiopathy or chronic endothelial cells injury. So we have to perform the immunofluorescence to get the answer of this morphologic pattern. I think I can.
My fellow
Okay.
to
Describe immunofluorescence.
Yep. Actually, from the immunofluorescence, which disease or which pathology pattern that you think is
The IgG is negative. The IgA is one positive, and IgM and C1q is negative, and C3 is 3+ level.
3+ located and pattern.
Located is
Location.
granular pattern
Granular
along
fine or coarse granula? Oh,
Fine granular pattern on mesangium
only
and
mesangium.
capillary wall.
Okay, both. And 3+ intensity, right?
Yes, 3+
And
intensity.
how about lambda and kappa?
The kappa is 3+ intensity in granular pattern staining at the capillary wall and mesangium, and
Similar
lambda
to
is negative. So there is kappa restriction.
kappa restriction. Do you think IgA is negative or trace or plus
I think 1+
1+?
or trace.
So this the IF is consistent with the clinical or immunofixation or not?
I think is correlate with
Correlate.
the provisional diagnosis and the lab.
So the immunofixation is the IgA kappa, right?
Yes.
And C3 strongly positive. So now what is your final diagnosis? Oh,
Okay.
no.
Sorry.
Actually, your final diagnosis from LMIF.
I think is
M-
C3 glomerulopathy from IgA kappa induced.
C3.
C3
Now you exclude
glomerulopathy.
MIDD, right?
MIDD.
Do you want anything to support you?
If there are signal in immunofluorescence in TBM,
Okay, Dr. Mangkon,
it
you
might
can
be
review
help,
that.
but there is no TBM staining.
Okay, Dr. Mangkon, you can go. You can go on.
Okay, I will go to the description of immunofluorescence study and the diagnosis. So IgG, I agree that it's negative, but IgA, I can see just trace granular capillary wall staining on the segmental area. It's just not remarkable positive. IgM is negative and C3 is moderate staining. I give 2+ on granular mesangial and granular capillary wall staining pattern, and C1q is negative. The kappa and lambda show restriction with kappa strongly 3+, granular mesangial and capillary wall staining, and lambda is negative. CAS show equal staining on both kappa and lambda in tubular CAS. So the diagnosis of this biopsy is proliferative glomerulitis with monoclonal immunoglobulin deposits, light chain only variant, or PGN-MID light chain only variant. This is why we call that the kidney biopsy, which is the first core biopsy specimen. So this patient.
Do you have, sorry to interrupt you, do you have EM?
And we this case there is no glomerular present on the tissue submitted for EM.
Okay.
But
Okay.
I didn't perform the retrieve from the live microscopic tissue. So the patient was performed bone marrow biopsy and show plasma cell myeloma with monotypic kappa restrict plasma cells. Okay, I have short review about this disease. This disease for PGN-MID or proliferative glomerulitis with monoclonal immunoglobulin deposits. It's not a quite rare disease, but it's not a common disease. The term PGN-MID was initially used by Nasser in 2004. This is the spectrum of monoclonal gammopathy of renal significance, or MGRS. Is the morphology of this disease is a glomerular deposition of monoclonal immunoglobulin with proliferative glomerulonephritis. This disease, the morphology mimics immune complex glomerulonephritis by light and electron microscope. So we have the diagnostic criteria for PGN-MID. So you should have all of the following, including light microscope with proliferative or membranoproliferative pattern glomerulonephritis. Or sometimes you can see a typical membranous glomerulonephritis pattern. The immunofluorescence or immunohistochemistry study should have monotypic deposits of the single immunoglobulin class, such as the single IgG subclass in case of IgG, PGN-MID, or single light chain isotype. But the usually form of this disease is IgG3, and rarely IgG1, IgG2, IgA, IgM, and light chain only. Electron microscope have to have a granular electron dense deposit in mesangial, subendothelial area, and or subepithelial locations. And the clinical should absence of clinical or laboratory evidence of cryoglobulinemia. I know that why Dr. Taleksa asked me about EM. So the histological differential diagnosis of nephropathy associated monoclonal gammopathy. This is an example of the case that you should differentiate, including PGN-MID, type 1 cryoglobulin, immunotactoid, and C3 coagulopathy with monoclonal gammopathy, and MIDD. So the morphologic pattern, most look similar as have MPGN pattern, or some have endoproliferative glomerulonephritis pattern. And some disease also can have membranous glomerulonephritis pattern. But MID usually the light microscope present with nodular glomerulosclerosis pattern. So we distinguish this disease by IF and EM. For PGN-MID, the immunofluorescence you should have granular staining in mesangial and capillary wall, in monotypic immunoglobulin staining, and also C3 staining is common. And electron microscope of the staining, granular staining should be non-organized granular deposits. But for type 1 cryoglobulin, the IF pattern is similar, is granular deposit with monoclonal or monotypic immunoglobulin, and also have C3 and C1q staining. But the difference is on electron microscope, the deposits usually have short microtubule substructure. And immunotactoid have glomerulopathy, have granular deposits by IF with monotypic immunoglobulin, and also positive for C3 staining. But EM show the parallelly arranged microtubules with vary in diameter from 10 to 72 or 80. But for C3 glomerulopathy that usually present with MPGN pattern, this disease have granular C3 deposit and predominant C3, but no or minimal immunoglobulin deposition, and shouldn't have kappa or lambda staining, or just minimal staining and no restriction. So in this case, we do not call C3 glomerulopathy. And this group of disease have divided into C3 glomerulonephritis and dense deposit disease by electron microscope pattern. And the last one, MIDD, or monoclonal immunoglobulin deposition disease, is have a typical finding by immunofluorescence with linear staining, not granular staining on glomerular capillary walls and or tubular basal membrane staining. By EM, they show punctate powdery deposit in the inner surface of GBM and outer surface of TBM. So this disease have just few subtypes, including IgG, IgM, IgA, or light chain variant. That you see, IgG is the most common form of this disease. approximately about 90%. But if you have IgG, the 70% are unknown. Just only 30% that patient have B clone, and just 10% that patient have plasma cell myeloma. If you have IgM, the second common of this form is about 5 to 10%. About 80% patient have B clone, B cell clone. For IgA, about 60% patient have B cell clone. But for the light chain, which is the rarest type, but also if patient have this type, it's common to have plasma cells abnormalities or B cell clone is in about 85%. So for PGN-MID, light chain variant is a rare morphologic variant of PGN-MID, but frequency detectable pathogenic plasma cell clone with a higher tumor burden compared to the other variants. In one study, PGN-MID light chain have nephrotoxic monoclonal immunoglobulin detected in the serum and urine in about 65% and 73% of the patient, and abnormal free light chain ratio in about 83%, and bone marrow biopsy show plasma cell clone in about 88%. For overall, patient have 29% of patient had multiple myeloma from this disease. Okay, thank you.
Anyone want to share any idea or asking Dr. Mungkon? It is interesting, but actually it depends on the way to call. I think this case definitely have a plasma dysplasia because we see the monoclonal plasma cell in the bone marrow, and we see the plasma clone monoclonal grammopathy in serum of the patients. But the way to call the pathology pattern is depend on pathologist. For me, I think we cannot differentiate from truly differentiate from MIDD, because MIDD maybe intact molecule, monoclone, heavy chain, light chain, or just intact immunoglobulin. So for me, it surely you need to have a electron microscope to see gunpowder to make sure that it's a MIDD or it's a PGN-MID. Because normally for PGN, as you review from the literature, for me, usually people think about IgG3 kappa monoclone. For the other, it's quite rare. For you, then you review as the IgM. For me, it's IgM maybe it's a heavy chain or Waldenstrom gammopathy. So that's why you need to have electron microscope to support the diagnosis. But as I mentioned, surely the patient have plasma dysplasia, but the cumular pattern, it depends on nomenclature or depend on pathologists to call this pattern. But the treatment for clinician, it should be similar to get rid of the clonal defect.
Yes,
Anyone?
I agree with your discussion. But for the pathology, we can distinguish PGN-MID and MIDD from the immunofluorescence pattern is the gold standard rather than electron microscope. That PGN-MID have a granular pattern staining by immunofluorescence, and MIDD have linear pattern staining. Because of the from electron microscope, but sometimes the gunpowder staining, if there is not quite diffuse or just limited in segmental, is sometimes that's why we also call random type or non-random type. So immunofluorescence is the key to differentiate this disease.
Oh, sometimes verify granuli is difficult to ensure that it's a linear or not. And sometimes linear is not truly linear if you go to higher power resolution. And for clinician, I think is same disease. It's probably it's plasma dysplasia, but it's the plasma may produce heavy chain, light chain, or intact molecule. It depends on the disease, but the treatment should similar. But the way to treat, to nomenclature, because we don't have a consistency classification right now. So I think it depends on pathologists to call them. And also C3 is this C3 or complement dysregulation. Sometimes they have a monoclone as well. So that's why it's add more complicated to the case. And anyhow, anyone want to share any idea?
Yes, we have question from BAH that how can we differentiate light chain immunotactoid from PGN-MID light chain without electron microscope? Okay, this is a good question. Basically, I cannot differentiate these two diseases because both have granular pattern. So EM is required. But that I told you that for this case, the tissue submitted for electron microscope is that there is no glomerulus available. So if I can perform from paraffin block from the tissue, but for in my experience to see immunotactoid fibril by paraffin block is very difficult because the morphology is not quite appreciate, like if you have fixed in glutaraldehyde or perform at the first time. So my decision to do not perform this case because I will wait for bone marrow biopsy first if there is an answer for the patient. So I know that clinician will treat similar.
Dr. Mukon, do you just brief we're talking about the EM classification of the deposit, electron deposit for fellow to get the take-home message.
Sure. So we have two big type of electron dense deposit that we have. Just a usual type is a granular pattern that have, like you can see in IgA or lupus nephritis. There's a usual type immune complex or electron dense deposit. And another type have substructure. If you see on the density area, you can see the substructure such as cryoglobulin substructure, which have very short fibril in diameter of about 20 nanometer, or amyloid fibril that really long, randomly arranged fibril but thin. Also, Fibry nephritis that have long fibril similar to amyloidosis but thicker in diameter. And immunotactoid which have parallel substructure and have more it's a thickest fibril by electron microscope. So we divide into types that have organized or non-organized.
Yeah.
The deposit that we also call technical term is organized.
Yeah, organized deposit or non-organized deposit. For organized, we do have a fibril form and tubular form. Okay. Anyone want to ask any question? If not, because the time limited and we over the time. So the final, before we leaving, should we have take a group photo? Please open your camera and we can take a last photo. And for the next time, we're gonna have we will have the next PD case discussion the first or maybe third or fourth week of January. I will decide and tell you later because we need to ask volunteer from Philippines or Vietnam.